Welcome, everyone. My name is Darshan Mehta. I'm the Associate Director of Education for the Osher Center for Integrative Medicine here at the Brigham Women's Hospital and Harvard Medical School. We're really delighted to have our team of presenters here led by Dr. Claudia Citkovitz from NYU Langone School of Langone Hospital. And before I introduce them, I just wanted to highlight a few upcoming presentations that we have. Next month, we are really excited to have Dr. Amy Cuddy from Harvard Business School, who, as some of you may know, has become renowned for her TED Talk entitled "Your Body Language May Shape Who You Are." So she will be presenting integrative medicine research seminar presentation next month on October 3rd at 8 a.m. right here. And then the following month, November 7th, we have an exciting presentation led by our own Matthew Kowalski at the Osher Clinical Center on an integrative approach to, we have upcoming presentation there, and that also will be truly a multidisciplinary team-based presentation. So we look forward to seeing you there as well. And I don't have the title is Integrative Approach to Migraines is the official title. Yeah, okay. So to migraine management. So with that, and following in December, we have Dr. Peter Cohen, who, as some of you he has written numerous pieces in journals, including New England Journal of Medicine and JAMA around dietary supplements, and he will be presenting a presentation on complementary integrative therapies for depression, state of the evidence as well. So with that, we're really excited to have, as I mentioned, the team from New York, NYU. Dr. Claudia Citkovitz has led the acupuncture service at NYU since 2004, supervising 10 acupuncturists who provide inpatient care and clinical instruction in the areas of neurological and orthopedic rehabilitation, labor and delivery, and pain management. She has numerous distinctions, but is really well known as an international leader in acupuncture practice and research methodology. She is on the editorial board member of the Journal of Alternative Complementary Medicine, and is also a past member of the NCC-AOM's Blue Ribbon Task Force for Hospital-Based Acupuncture as well. So, and I'll ask Dr. Citkovitz to introduce her colleagues as well. But we have, again, a presentation on acupuncture therapy during acute and subacute stroke rehabilitation. Dr. Citkovitz.
Oh, not in the front? Okay. Over here. Hi. Thank you so much, Dr. Mehta and Peter and Helene and the Osher Institute. We're honored to be here. And also really grateful that all of the therapists were able to come up, and that our wonderful patient, Mr. Jung, was able to come up. So thank you for making that possible. And also a big thank you to Lisa Conboy and Kayin Shu at MCPHS. I've been kind of bilocational at MCPHS and NYU Lutheran all this year, and so it's wonderful to be able to be right here, right now. We have a few learning objectives for those doing continuing ed, how acupuncture supports the stroke rehabilitation process, why acupuncture during stroke rehabilitation is best understood as a complex intervention, and what main types of therapy are used during stroke rehabilitation. So the way that this morning will run is that Stephanie Wu, who is the physical therapist who worked primarily with Mr. Jung, will present his initial case presentation as he came to the hospital. I'll talk a little bit about what acupuncture therapy we did with him, and then Lauren Glokler, the wonderful speech therapist, speech language pathologist, will discuss what speech interventions were done, and then Jasmine Tam, the occupational therapist who worked with Mr. Jung, will discuss the occupational therapy. Stephanie will speak specifically to what she did for physical therapy, and then Mr. Jung and his daughter Lily will also say a few words about their experience, and I'll do a very brief summary, and then we'll leave as much time as we can for discussion. So, Stephanie.
Hi, my name is Stephanie. I'm the physical therapist. The patient is a 60-year-old male with a past medical history of hypertension, but he wasn't taking the medication consistently, and he experienced a sudden onset of right side weakness and slurred speech on March 13 in a shopping mall. CT scan did not show any acute hemorrhage or pathology, but MRI scan showed that he had a cerebral infarction due to the occlusion of left middle cerebral artery. And the patient had severe right hemiparesis, dysarthria, aphasia, and apraxia, meaning the patient had difficulty expressing himself and understanding others. And he was completely dependent with activity of daily living, communication, and mobility. He participated 3 hours of physical therapy, occupational therapy, and speech therapy daily in acute rehabilitation. So the patient was admitted to NYU Langone Augustana Subacute Rehab on April 11, 2017. In the initial speech evaluation, the patient demonstrated difficulty with simple to moderate level of verbal information, which means that he had difficulty understanding if someone said, how are you? And he also has significant difficulty expressing or verbalizing simple information. He wasn't able to say something as simple as his name. He was not a functional communicator of his basic wants and needs. Like, he wasn't able to tell people when he needed to go to the bathroom or when he was hungry. And next slide. In the initial OT evaluation, patient had very limited movement on the right shoulder and elbow, and he had no movement on the wrist and fingers. He also had moderate flexion spasticity on the right hand, which means that the patient would be holding his hand in this position most of the time during the day. And according to the FIM outcome score, the patient required maximum to moderate amount of assistance from another person to complete his overall daily activities. In the initial PT evaluation, the patient had no isolated movement of his hip, knee, and ankle joint, which means that he cannot move each of the joint independently of the others. He had moderate to severe extensor tone of the right lower extremity, which means that the patient usually have his right lower extremity stuck in this position. And he also required a moderate amount of system for transfer, which means that he would require about 50% of effort of work that needed to be done by another person to complete a task such as moving around in bed or transfer from a surface to another surface or from a sitting position to a standing position. And he, in terms of walking, he was walking with a hemi walker, require about maximum amount of system from one person, which is about 70 to 99% of the work from another person, helping him to walk. And during walking, he was only walking less than 10 feet at that time. And he was unable to perform hip, knee, and ankle flexion to bring the leg up. So he would have to push his body backward, lean back, and thrust his right hip forward to make so as a compensatory strategy to make a step. And at the same time, because he wasn't able to bring his ankle upward like this, so he wasn't able to clear his foot when he was walking. So he would have a foot drop presentation when he was walking. Okay, now Claudia is going to talk about how acupuncture is going to benefit the patient's stroke rehabilitation.
Thank you, Stephanie. Acupuncture, just as a little background, pretty well understood as putting needles into places where they're understood to work on the basis of the historical theories of channels or meridians, they're sometimes called. But the scope of practice really importantly includes placing needles for other modern reasons. Placing them in the ear, in the scalp, manual stimulation, tuina, we call it Chinese medical massage, electrical stimulation, attaching small charges to the needles, and others. So when we say acupuncture therapy, it's really important to understand that we mean the use of a full range of approaches and at the practitioner's discretion, as distinct from this point here, that point here, that point there. It's best to understand acupuncture therapy as a complex intervention, meaning an intervention that has multiple interacting components, very similar to the PTOT and speech therapy that this patient also received. So current best evidence, it's worth noting that acupuncture is used more in China for stroke than for anything else, including pain. There is a Cochrane review of acupuncture for stroke, even though it's less well understood for that use here. Relatively, effusive for a Cochrane. We found a few possible areas of improvement, studies low quality evidence, as is almost always the case with Cochrane reviews of acupuncture. They looked at death, dependency, institutionalization. They didn't include any randomized controlled trials. However, there are a couple of different kinds of trials, post hoc analysis, and some work I did in 2015 suggesting that can be reduced. Neurological deficits, they call that dysphagia, urinary retention, depression, shoulder pain, and important to note, no adverse events. For this patient, aphasia, of course, was the main challenge. And so the good news is there are a number of Chinese trials. The bad news is that, as is often the case, the quality isn't so certain. There are some good ones, including this one, Chang, relatively recent, 2017. Upper extremity recovery, the literature is inconsistent. We think, based on a really good study way back in 1994, here, I think, in Boston, that the acupuncture can't help if the hardware is gone. Then there's no software to reprogram, and because the middle cerebral artery sits right over the upper extremity motor line, a fair number of patients just do not get their upper extremity movement back, despite best efforts of therapists and acupuncturists alike. So a very brief look at the evidence-informed practice framework that I made as part of my PhD research in 2015, kind of based on what we'd been doing at the hospital since 2003. Here you see kind of a stage through of the different ways we look at helping the patient's body recover from stroke, and then the stroke rehabilitation. So the recovery goals, first step, not so relevant to this patient, but if it's within 7 to 10 days of the stroke, then increase circulation to the head as much as you can, hoping to reduce the ischemic penumbra. If there are level of consciousness problems, that's when to address them. Then step 2, immediately, in Chinese medicine, any disruption of food or fluid metabolism is a federal case and has to be treated urgently and immediately. So we, immediately get the plumbing back functioning as quickly as you can. And then still part of recovery for us in Chinese medicine is to balance the constitution. So if they're yin and yang are out of balance, their qi and blood flow. Then on to the assessment and treatment planning. This is actually the same 7 steps, just written out in a different format that we use in our day-to-day charting. So speech and swallowing come first in the rehabilitation therapy because there's such a problem. If you can't receive and send communication, you can't participate well in the rest of your therapy, and swallowing is key for your body to heal. Balance and trunk stability comes before lower extremity motor return because a patient with poor balance and trunk stability and good leg strength is more dangerous than a patient with bad leg strength in that situation in terms of fall precautions. And then, as discussed, upper extremity return actually often comes last and sometimes just doesn't come. So although we do always want to get to it, if there are other goals that are more kind of tractable, we really try to work very hard on those first. So the therapy approaches used in rehabilitation to realize those treatment goals. We have the historical kind of channel or meridian-based acupuncture. We have ear acupuncture, which is a modern usage. And then we have scalp acupuncture, actually a couple of different types of scalp acupuncture and ear acupuncture. Again, a modern usage based on where's the motor area, where are speech areas. So as you'll see, we use a combination of these different types of approaches. Here are a couple of quick pictures. You can see the scalp needles and the ear. There's acupuncture, and also these little beads are placed to put acupressure in the ear. Electrical stimulation, and then at the bottom, that's me doing Twaina manual stimulation to help with a spastic foot. So in terms of what we did to diagnose and treat this patient, first we saw him in acute care. Only twice. The first treatment we treated primarily constipation and also did some points for aphasia. The second visit, the constipation was resolved. We again treated with the TCM acupuncture, traditional Chinese medicine acupuncture, the channels and meridians. And during the session, the independent recall of family names improved somewhat. So even within the session, we felt as though there was improvement. But both in that acute care and also in the first few weeks of his subacute care, the dose was a little low. The NYU Lutheran program is it's a school-based program, and we were on semester break. So between semesters, the staff were kind of on a skeleton crew, scrambling around to treat everybody as much as we can, which isn't as much as we would like. We like to treat 3 times a week. We'd prefer to treat 5 or 6 if we could. So we continued with aphasia. We were able to increase the dose as the students came back, predominantly the TCM acupuncture and also scalp points over, Broca's and Wernicke's area and other scalp areas. So in the beginning of May, we added a new treatment principle because Jasmine said to us, well, he's been doing so amazingly with his speech. Maybe it's the acupuncture helping. Do you think you could work on his shoulder pain, which is, making the sessions difficult and giving him problems? And the patient had also Mr. Jung had actually also told us he wanted to move his arm and could we help? So we jumped the queue a little. Shoulder pain is very common and a real problem in stroke patients. So we worked on that as a pain issue. And then we also did the scalp acupuncture for the upper extremity a little sooner than we might have because we're so excited to have a patient request, and also we wanted to help Jasmine out. Then in the middle of May, we added another treatment principle. Stephanie let us know that he had high tone in his hamstrings and also difficulty with synergy, with using the muscles together. He was getting good improvement of strength in the muscles individually, but that he was not using them together well. Again, as is common with these deep middle cerebral artery strokes. So we continued to do the TCM and scalp acupuncture we had been doing in conjunction with Lauren and the speech therapy, but we also co-treated in physical therapy. We did those ear acupressure beads and also a few needles in the scalp over the leg motor area. And the scalp needles are very stable, so it works just fine to have them in active during the physical therapy. And it really did seem as though there was improved synergy within that session. So then weeks 8 to 10, we continued with the upper extremity mobility, which was starting to come back very excitingly. And also working on dorsiflexion, which, as Stephanie said, if that doesn't come back, as it often doesn't, then you wind up needing an ankle brace for life. And so the electrical stimulation we used either on the arm or, if you can imagine that this is my foot, we use the electrical stimulation to make a twitch, and then we get the same twitch going in the appropriate motor area, whether it's arm or leg, using a kind of a fire together, wire together principle, so that although, of course, no electricity goes into the brain, we're right over the area that wants to be stimulated. And that's something we've been doing for a while, and we really do feel like experientially that it helps quite a bit. And then towards the end, he's getting ready for discharge, but he got a cough, which is a big problem for stroke patients. So we sort of switched over. We didn't forget about the aphasia, but we switched over to treating the cough as much as we could in order to get him ready for discharge to go home. So I'm going to hand over to Lauren. Thank you.
Hello, I'm Lauren from Speech Pathology. Thank you all very much for coming, and thank you for having us here. We are thrilled to be here. I'm going to be talking a little bit today about Mr. Zheng's progress in speech therapy, as well as his recovery outcomes. So some of the research shows that higher frequency and higher intensity intervention has greater outcomes for patients that have suffered from a stroke, as well as intervention targeting word retrieval tasks does show generalization to spontaneous speech and in conversation. During his initial assessment on 419, Mr. Zheng had significant difficulty expressing himself. He could not generate spontaneous speech, he could not initiate conversation, or find words to produce clear, cohesive sentences, which impacted his ability to be a functional communicator, even with familiar speakers, even his family members. He also demonstrated difficulty with problem solving and safety awareness, which is a huge concern for us in return to home. We want to make sure that he's safe, he's able to participate in activities of daily living in a safe manner, so that when he goes home, he doesn't end up with another fall or return back to the hospital. He had one of the aspects that we focused a lot on was repetition. Although repetition was grossly intact with words, it diminished with sentences. So this really became the foundation for our therapy. We wanted to increase that spontaneous speech, that word retrieval, to be a functional communicator. During his intervention, Mr. Zheng made steady gains in his ability to produce clear, cohesive speech. He was able to repeat functional phrases with moderate assistance, including a use of a pacing board. His comprehension grossly improved for ability to follow commands and respond to questions appropriately, ability to kind of gather his wants and needs by asking yes/no questions. So that was really important for us. So again, staff members, family members could communicate with him effectively and make sure that his wants and needs were being met. Additionally, he made significant gains in word retrieval skills. He was able to complete confrontational naming tasks with almost 100% accuracy with minimal cues. This really, I did see a translation to this in his conversational connected speech, where he was able to, with moderate assistance, produce functional phrases with minimal assistance to get those needs across. He was making gains in the word retrieval, as I said, as well as in generating sentences independently to convey those wants and needs. At the end of our intervention, Mr. Zhang was a functional communicator of his basic wants and needs, ability to communicate with family members and staff members to show what he wanted and get the things that he needed met. So we were thrilled with the progress he made in conjunction with the acupuncture therapy. I even Stephanie, the physical therapist, she would come running to me. We had to do our sessions with an interpreter. He speaks Mandarin. So Stephanie, the physical therapist who speaks Mandarin, she would come running to me after session saying, oh my gosh, he produced a whole sentence by himself. He was telling me how he felt during the session. He was telling me, you know, that he had pain in his arm or leg when he was moving. He could tell me that he was doing a good job or what he needed more assistance with. So that was really awesome to see that level of connection and that progress across our sessions. So next I'm going to hand it over to, this is just data to show the progress that we've made per my treatment goals. So I'm going to hand it over to Jasmine Tam so she can give you some information on the occupational therapy section.
Thank you, Lawrence. Okay. Hi, my name is Jasmine Tam. I'm the occupational therapist. When Mr. Zhang first came in, like this is his presentation, like he has very limited like shoulder range of motion. There's no movement in the wrist and the hand, and he require like max to moderate assistance for his daily activity. So our goal for him, like very straightforward, is to regain the range of motion on the arm and also the strength, working on his balance. So just to, so he can do the daily activity stuff like toileting, dressing, bathing, like by himself, like as independent as possible. So this is the first 3 weeks, like he received the occupational therapy. He has some gain in the shoulder flexion, like from at the beginning 0 to 10, now like jumping from that to 0 to 70. The elbow is really good, like 20 to 70 active range of motion, but there's still